Introduction: I start by introducing myself and asking patient for consent. Then asking a few questions to assess for any abnormalities in speech, orientation, level of consciousness, and memory. Cranial nerve 1: I will get the patient to occlude one nostril and breathe through the other. He will close his eyes, smell a substance, and then name the substance. This is repeated in the other nostril. If the patient cannot identify the substance, it is called anosmia. Hold the chart half a hand distance away with one eye closed, read the smallest line, and then repeat with the other eye. The patient has 20/20 vision. Visual field: standing 1 meter away, I get the patient to cover one eye and look directly into my eye. I will move my fingers towards him until patient can see my fingers and how many I am holding up. Done from all 4 directions. For time, we only demonstrated this with one eye. If point has poor visual field, then I would conduct a perceive light test. Fundus exam: I check to ensure the optic nerve is visible and the optic disc is well defined with circular shape and demonstrating a healthy optic nerve and macula. So with the ophthalmoscope, I stand at distance of 15 inches and come in at a 20-degree angle from the patient. I can ensure that the optic nerve is visible and the optic disc is well defined and is yellowish-orange in color. To follow my finger as I move it and to let me know if they are seeing double at any point. Moving my finger in the pattern of AH and doing each side with one hand. Patient did not report any double vision and there was no nystagmus. Pupil light reflex: patient is going to look straight ahead at the wall far away. I will shine the light into each eye looking for brisk direct and consensual response is present with brisk constriction of both pupils. And then repeat in the other eye. Swinging light reflex: having the patient maintain a view at the wall far away, I will swing the light from the side checking for consensual eye constriction and repeat in the other eye. If light is swung into eye and both pupils dilate instead of constrict, this finding is known as Marcus gun pupil. Accommodation: now I will check for accommodation. Asking the patient to keep his head straight, avoiding movement and staring at a far distance. Then I will have the patient look at my finger, checking for patient's pupils to constrict when looking at my finger and dilate when looking far. This is to rule out Argyll-Robertson pupil. Convergence: asking the patient to keep their head still and to follow my finger as I move it in and out. To close their eyes tightly and checking for the tone of the temporalis and masseter muscles. If there is a weakness or jaw deviation on one side, it could indicate a lesion on the side of weakness. Sensory component: pain sensation with patient's eyes open. I show him dull and sharp. Then getting him to close his eyes and identify when touched with sharp versus dull. This is done in all 3 parts: the ophthalmic, maxillary, and mandibula. Since pain is intact, we assume temperature sensation is also normal. If patient was not able to feel pain, it would be called facial analgesia. Touch sensation: I will have the patient close their eyes and say yes every time they feel a touch and ask if the touch felt the same on both sides. Testing the patient's touch sensation. If patient did not feel touch on one side, then it would be called facial anesthesia. The cranial nerve 5 and 7 are intact. Diminished corneal sensation could indicate Bell's palsy. 7th cranial nerve: I ask the patient to close his eyes tightly as I try to open them. I ask him, can you lift your eyebrows? Here, I check for forehead wrinkling, then ask the patient to puff out his cheeks and resist my movement. Then I ask the patient to smile and frown for me. Then I will conversate with the patient to check for facial expression, weakness, tics, or involuntary movement. I occlude the other ear and have the patient repeat it back to me. Tuning fork test: I'll start with Weber test. I place this on the middle of the patient's forehead, asking patient if they feel the vibration on one or both sides. Rinne test: next is the Rinne test. I place the stem of the tuning fork against the mastoid process behind the ear. Asking the patient let me know when they no longer feel a vibration, then I move the tuning fork close to the pinna. A normal result is depicted by air conduction being greater than bone conduction. Now, I ask patient to stick his tongue out and move it from side to side. 11th cranial nerve. I am going to place my hand on the patient's cheek and have them turn their head in the opposite direction against my hand while I note contraction of the opposite sternocleidomastoid. Now to assess the trapezius muscle, I have the patient elevate their shoulders, augment my resistance, checking for equal rising and no shoulder drooping. Now we move on to the motor component of the exam, where I will be checking for bulk tone and strength of your motor components. I am noting for any loss of balance, coordination, and involuntary movement. I am lightly squeezing the patient's upper and lower muscles to check for atrophy. Tone, I'm going to ask the patient to relax all his muscles and let everything loose. I will be moving his limbs passively to feel for any resistance. Here I am passively flexing and extending to confirm there is no hypertonia and hypotonia. I will also hold the foot in a dorsiflexion position to check for clonus. Strength. Next will be assessing muscle strength by having patient flex and extend the upper and lower limbs, including wrist, ankles, and fingers, and having patients pull or push against the resistance. I will also hold the foot in dorsiflexion position to check for clonus. All movements had a normal strength is grade of 5. I start with the bicep tendon reflex. This should elicit contraction of the bicep muscle and flexion of the elbow. Then I test the brachioradialis. This should elicit flexion of the arm and elbow with supination of forearm. Next is the triceps reflex. This should elicit contraction of triceps with extension at elbow. Now I check the patient's patellar reflex. This should elicit contraction of quadriceps with extension at the knee. Then I check the Achilles reflex. Should elicit plantar flexion of the ankle and foot. Lastly, I check for Babinski sign. Using the end of the reflex hammer, I'm going to stroke the lateral aspect of the sole and up towards the big toe. A positive Babinski test would occur if there is fanning of the toes, and that would indicate an UMN lesion. Sensation. Now I'll be checking the patient's sensory function. I'll start with testing pain sensation, which is mediated by the lateral spinothalamic tract. I show patient this is sharp and this is dull. Now I get patient to close his eyes, asking if is this sharp or dull. If the pain sensation is normal, temperature can be assumed normal as well. Touch sensation. Now, I will be moving on to checking for light touch sensation, which is mediated by the anterior spinothalamic tract. Showing patient what it should feel like. Now asking patient to close his eyes and say yes when he can feel the touch, and where you feel this touch, and if it feel the same on both sides. Vibration. Next, I'll be checking for vibration sense. Using the tuning fork to the distal interphalangeal joint of the finger, asking patient to let me know when you feel the vibration as well as when it stops. If the vibration cannot be felt, I would move to a more proximal location. I do the same thing on the big toe. Proprioception. Next is testing for proprioception, where I grip the side of finger joint. I am checking for joint position sense. I orient the patient to right, left, up and down. Now I ask patient to have his close your eyes and tell me what direction I'm moving. If patient cannot recognize the position of the finger, then the lesion is in the fasciculus cutaneus. Then I do the same for the patient's toe. Position sense are intact. I will now proceed to discriminatory sensation graphesthesia. I am checking for graphesthesia on the patient's palmar surface. I'll draw a number and ask you to repeat this for me. 2-point discrimination. Next is the 2-point discrimination test on his fingers, where the patient will identify 1 or 2 points of a paperclip and let me know when he feels whether it's 1 point or 2 points. In a normal result, this should be less than 5 mm. Point localization. I'm going to have the patient close his eyes while I touch different regions, then have him open his eyes to localize where this was felt. Cerebellar function. Now I am going to assess for cerebellar function. I am looking for any abnormalities in speed, rhythm, And smoothness, I'll start with rapid alternating movement. Next is the finger-to-nose test. I'm going to place my finger in front of the patient. I will ask him to touch my index finger and then his nose and to continue to repeat it. Next is past pointing. It is done to test the integrity of the cerebellum with the patient's arm completely stretched and getting him to touch my finger across from him with his eyes open, then asking him to continue with eyes closed. Next is the heel to shin test. I have the patient place his right heel on the left knee and run down the shin, asking him to do with his eyes open and then with his eyes closed. Here we are again looking for smoothness and accuracy of movements. Gait abnormalities. Now I will be checking for gait abnormalities. I'll start with having the patient stand up and walk straight, while I keep my arms up around the patient in case of lose of balance. I am noting for balance of his body and movement of leg. Next I'll have the patient tandem walk, walking heel to toe. Next I'll ask the patient to walk on their tiptoes, testing for plantar flexion and strength of the muscles. Then I ask him return on his heels, assessing for dorsiflexion and strength of the muscles. Next I'll have him hop on one leg. This indicates that motor system and strength are intact. Then is the shallow knee bend. The patient will lower down on one knee. Romberg test. I ask the patient to stand feet together and arms spread to the side. Then I ask him to close his eyes. I am checking to any swaying of the body. If trouble balancing occurs with eyes closed, then it's a posterior column lesion with sensory ataxia. If imbalance noted with eyes open, this indicates a cerebellum lesion with cerebellar ataxia, which is a Romberg test positive finding. Pronator drift. Next is pronator drift, with patient standing with arms in front and supinated, and have them stand with eyes closed for 30 to 40 seconds. Pronation of one arm suggests lesion in contralateral corticospinal tract. I will then push them downwards and they should return back to their spot. This concludes the physical exam, and no abnormalities were found in patient's neurological functions.